was the thing. Okay, so yeah, don't be freaking out about those scores. But know that part of the rationale for Kaplan is understanding how to take and how to analyze and correctly answer NCLEX questions. So I'm going to do this second, because first, now I didn't bring the exam questions in. I apologize. I spaced it this morning. There was a question that everybody missed, which I, of course, gave back. But it's a classic NCLEX question, which is why it was on there. And I took it off because clearly I didn't do a good enough job of explaining how you need to think about stuff. Do you all remember the question that talked about the AIDS patient who came in with nuchal rigidity and fever, blah, blah, blah? Okay. And the two correct choices, and they're both correct, it's just one's more correct than the other, were meningitis and toxoplasmosis. So why is it not meningitis?
Meningitis is the symptom, essentially. That's like the inflammation.
You're right. So meningitis is a generalized inflammation. And what was the key word in that question that should have pointed you to something more specific than meningitis?
I don't know.
They were an AIDS patient. AIDS patients are very susceptible, along with pregnant women, to toxoplasmosis. So if you have a patient that's pregnant or AIDS or both, and they come in presenting with these symptoms, you need to be thinking about toxoplasmosis. Now, why is that important? Well, yeah, kind of. Okay, it's more about, does your care for that patient change in any way based on knowing that it's toxoplasmosis versus bacterial meningitis?
Yes, because isn't it what medications you use? I feel that's right.
So what kind of precautions will you be on with a bacterial meningitis patient? They're going to be in a negative pressure room. They are highly contagious. Toxoplasmosis is not. So it's going to change your nursing care and your plan of care knowing that it's probably toxoplasmosis. Not to say that you're going to be less careful or anything, but being able to be more specific in your answer gets you closer to doing a better job as a nurse. And that's why in that question, the answer was toxoplasmosis, and the hint was AIDS and toxoplasmosis, because toxoplasmosis is a very frequent opportunistic infection for AIDS patients. And if you're pregnant, don't take care of cats. Don't do the cat litter, because that's one of the more common sources. So if you're cleaning out the cat litter and the dust and stuff, and you're breathing it, which you're going to do if you have cats. I have cats. Yeah. I try and leave that at home, though. Okay. Well, I leave the cats at home. They don't like traveling. So why is this concept map up on the board here? It's a beautiful concept map. And it's a great example of what I realized as I was answering a number of questions about particularly nursing priorities that I need to explain more about what I mean by nursing priorities, which may be different from what your last professor meant or the next professor means. For Bob's class, nursing priorities focus on every time I walk into the room, is my patient the same, better, or worse? What can I do in the moment to assess whether they're the same, better, or worse? I can talk to them. Is their mentation the same? Are they the same level of consciousness? Are their vitals looking okay? Has there been any change? And knowing the background of my patient, because I know their history and I got report, if I'm concerned that they might have respiratory issues or cardiac issues, I'm going to walk into that room and say, what should I be looking for? Well, I'm going to be looking for anything that indicates hypoxia. Are they getting anxious? Or is their mentation changing at all? Is there a change in the level of consciousness? Or if there's anything messing with their electrolytes, what can that lead to? dysrhythmias. I'll be watching their monitor. I'll be looking for them talking about, I'm having palpitations. Maybe they're not on a monitor, but I keep having heart palpitations. And that's what you'll hear. If they're having PVCs, preventricular contractions or PACs, pre-atrial contractions. Very good. Those are the things that you can assess in the moment. You don't need to send them to the lab. You don't need to, you don't need to do an EKG. You don't need to draw a lab. You don't need to send them to X-ray. And that's a really big part of your job as a nurse. Is every time you walk into the room, it's like, it's everything the way it should be. Lines are good, drips are running, everything's, and it includes, is the patient where you expect them to be? Are they getting better? Are they getting worse? So that's my whole thing about nursing priorities. So we have a patient here, and I love this. This is a great map because it kind of shows all the interconnections. I should probably reduce the size here. Picky. So family history, we know what's going on, what's relevant, past physical exam. We kind of know not only what's going on, but you notice everything's kind of hooked together. The drugs are matching in with the symptoms and what we're treating. But in particular, in these priorities, and I've noticed that there's been a couple of people who don't seem to actually be prioritizing their priorities. By that to me, priority implies that the most important is first. The second most important is second. So if you list fluid overload followed by shortness of breath and dysrhythmia, you got it backwards. What's the most immediate thing? What's going to kill my patient first? Well, let's see. They can't breathe and their heart's not working. I'll worry about fluid overload later. So this was very nicely done. Assess for shortness of breath, dyspnea, auscultate, monitor the cardiac status, level of consciousness. Excellent job. I don't know if it's a person in this class or somebody else, but that's kind of what I'm looking for. There's probably, in fact, a little more detail here than you really need. It doesn't have to be quite that extensive, but if you're thinking this way, you're going to do just great. And for all of those who are worried about, did I do a good enough job? If you did it, you get credit. I'll start getting more picky as the semester goes on. And no, I haven't posted the next case study yet, and I hope to get that done tomorrow, because people are asking already in the morning classes, when is that going to be due? Yes.
So what about, I can kind of read that.
Oh, I'm sorry.
But, no, it's okay. I got one. But what about the aspirin, NSAID, and acetaminophen? It seems like the two are not helping that patient out at all, especially with renal failure. I was curious if
Well, you may have renal dosing. We don't really know a lot about this patient. This is a patient that sort of just showed up, and this is their status. So I don't necessarily know enough to answer your question about, they're a dialysis patient and they're on NSAIDs.
Yeah.
Maybe that's not a good choice. But maybe that's what they've been taking at home. Your patients will come in and they'll say, oh yeah, I take Motrin. Well, is that a good idea? I don't know. I was in my pharm class this morning, we were talking about acetaminophen versus Motrin, ibuprofen. Now, do you all know that there's been a change from the FDA about how much acetaminophen you're supposed to get and what the max dose is per day? I think it's 3,200 actually, but I could be wrong. It used to be 4 grams.
Yeah.
4 grams in 24 hours.
Yeah. Why did it change?
Killing people's kidneys.
Not the kidneys. You're thinking aspirin.
The liver.
Yeah, this one, right. So, and why is that happening?
Because all the other meds are given.
Everything has Tylenol in it. Well, acetaminophen, Norco, Vicodin, NyQuil. You look at all those meds, almost every one of them will have acetaminophen in. So somebody's on Norco, and they're getting a nice little buzz, and they're already at 3 grams. And, I got a little cold. And they start chugging the NyQuil. And they end up in liver failure. So there's a massive level of liver failure going on in this country right now, and a lot of it's tied to acetaminophen.
Why they put so much acetaminophen in painkillers?
Because it
Makes sense.
because it works, and it doesn't cause. Okay, so this is here's my thing now. Okay, I think you all know I'm on Coumadin, right? So should I take Motrin? No, I shouldn't. But I really, at this point, I actually try and manage my Motrin with my arthritis versus acetaminophen because I can monitor my INR and I can't monitor my liver easily. Plus, Motrin seems to be, for me, it's a wonder drug. It works. If I get a migraine, Motrin works for me. So I don't take it very often, but if I'm really having aches and pains and I feel really lousy, I take Motrin. I know, yes, I should take acetaminophen. So I'm not even I'm not compliant, knowing fully what I'm doing, and I've read the research that says what I'm doing is dumb. And yet, so well, it hurts today, and okay. So that's where, yeah, John.
So they're putting Tylenol and everything, like they used to put alcohol and morphine and everything, and caffeine.
You used to be, you used to be able to buy codeine over the counter. Codeine cough syrup. It was good stuff. Codeine and 10% alcohol. It was a good old high. See, you guys are all born too late. Okay. All right. So does that help clarify where I'm going with concept maps and what I'm looking for? Yeah, Paul.
I don't understand why you shouldn't take Motrin with Coumadin.
You don't?
It's ibuprofen. Oh, ibuprofen is not there.
You sure about that?
Pretty sure, but I guess not.
You better go look at NSAIDs. The entire class are antiplatelet.
Oh, okay.
They make platelets less. Aspirin's one of the worst.
Yeah.
If aspirin were discovered today, it would be prescription only.
Right.
So, yeah, no, that's why you're not supposed to mix the two, because it'll increase your bleeding time. And then again, it's like patient education. I don't want to take Plavix because I ride a motorcycle a lot. And if I'm in an accident, there's no reversal agent for Plavix. And if I'm bleeding up here, it's like goodbye, Bob. With Coumadin, at least they can give me
Protein fulminant.
vitamin K would be better. That would be for heparin. Protamine sulfate?
Yes.
Yeah, know those for the NCLEX. You want to know the antidotes for Coumadin and
On the cardiac tip.
yes, and also, speaking of Coumadin, what are you going to educate your patients about their diet?
Don't drink alcohol.
Well, that would be that. No, that's a good one, but it's not the one I was looking for. Dark leafy greens are high in vitamin K. And of course, my poor mother, she's like, I really miss my salads. And it's like, Mom, you can have a salad if you sort of have the same amount every day. Oh, the doctor said I can't have salad. It's like, okay, fine. Okay, hey, what do I know? I'm just a nurse, right? Well, what you do is you discuss this with the pharmacist, and then they're going to go in. You have your labs drawn like that, and well, that's being on Coumadin. Yeah, you leak. They'll tell you they would rather you didn't, but if you're very consistent about it, then they can adjust your Coumadin so that your INR stays where it needs to be. But that means you need to eat the same amount of salad every day. And if you love to eat salad every day, then you're good to go. Or the same amount of vitamin K. Shall we talk about heart problems so that we don't run out of... I ran out of time this morning and I was very embarrassed. But then again, I do that frequently. So Mr. Clinton was known for his proclivity for eating Big Macs. I think he liked the double Macs. I don't remember.
A double Mac?
He liked cheeseburgers. I think it was cheeseburgers. I shouldn't put a brand on that.
I didn't know they make double Macs.
I haven't been in McDonald's in a very long time.
Double quarter pounder.
I'm more of a Burger King kind of guy. You know, the problem with In-N-Out is it actually has no flavor. But anyway, well, that's my opinion. My opinion. I make my own burgers. A little bit of garlic, a little salt, pepper. Okay. So moving on to Bill Clinton here. So a lot of us.
I did not have sex with that woman.
Well, neither did I. So that's good. Okay. So coronary heart disease is the largest single killer in this country. And the incidence has actually been dropping. Kaiser's very proud of that. They'll tell you about how their program has actually. I mean, they have demonstrable results where they've lowered the rate by 20%. And they've sort of in that process proved the model about in an HMO, if you follow a patient over a long period of time and help them manage their lifestyle, you can really reduce not only the healthcare costs, but you can increase their quality of life. So that's a good thing. And so people are doing things like monitoring their cholesterol intake, and they're doing a better job of managing their diabetes and hypertension, although you'll probably find most of the patients you take care of in the hospital, if you ask them about how well they're doing managing their diabetes, will say, well, I check my sugar every once in a while. But, the problems are that, the diabetes and hypertension are still very prevalent, and, both of those are primary causes of heart disease. And acute coronary syndrome, ACS, which you will see in your notes, it'll say ACS. So you know that one now, ACS, acute coronary syndrome, which is basically defined as a buildup of plaque in the arteries and with periods of ischemia that can lead to injury or myocardial cell death. So when you have cell death, what's that called? Infarct, right. Or infarction, either one. Now you all know normal heart anatomy, don't you? You know where the coronary artery is, and you know where the LAD. So let's talk about that blood flow. So it starts out on the right side and goes through the vena cava into the right atrium, into the right ventricle, and into the pulmonary artery, lungs, pulmonary vein, left atrium, left ventricle, and out to the body and back to the heart. What's the only artery that carries deoxygenated blood? Pulmonary. Good. You guys are much more awake than the morning. What's the only vein that carries oxygenated blood? Pulmonary. Yeah. See, that's a give me. Okay. Yeah, you'd be amazed how people get tricked by those trick questions. Where was I here?
Pulmonary vein. Pulmonary.
No, well, I'm trying to figure out where I should be in terms of back to the heart. Yeah, when does the heart actually get its own blood?
At the end.
At the end of what during the official cycles of the heart, when does the heart get blood to feed the muscle?
When?
Yeah. Diastole. Perfect.
When it's relaxed.
Yeah, diastole, when it's relaxed. So that's, when the ventricle squeezes down, I mean, the whole muscle, I don't know if you know, the muscle actually does kind of it rings. It's not a squeeze. It's more like ringing. It's like wringing out of, a wet rag. And when it squeezes, is blood going to flow into the vessels in the heart? No, it's all crunched down. So when it relaxes to fill, that's when the blood is flowing from the coronary artery back into the heart. And so, the ventricle has ejected blood through the aorta, and that valve closes with the back pressure, and when that valve closes, it also flows blood back into the heart. So if your heart's running at 150 beats per minute, does it have much time to refresh itself with its own blood? And if you're my age and it's running at 200, are you in good shape? No, you're probably hurting. You probably will have troponin leaks. We'll talk about troponin later, but tricuspid and bicuspid valves. Tri, 3, bi, 2. Also, mitral. Do you know what it's named after the Cardinals hat. I think it's the mitre. There. Yes. And I'm not Catholic, but if you're Catholic, you should know what that is, right? No? They don't teach that in Catholic school? Oh, my God. Okay. Where are we here? Oh, we're only on slide 2. I better get rolling here. So, coronary arteries. Oh, I turned 2 pages. No wonder I'm confused. I'm going to develop a heck of a reputation. So, this is the normal. When things are good, things are good. Which artery probably do you not want to have blocked? Right. And what does LAD stand for?
Left anterior
Descending, yes. So, have any of you? I know that in my clinicals, some of you are working on the teleunit, with the in the step down. And when you're reading the histories, have you seen like 60% occlusion of the LAD? Anybody seen anything like that, or 90%? So, what does that mean about that patient? Oh, maybe. Well, what else does it? What's probably in the moment? What's more critical about a 90% occlusion? You're fired. She was messing with something. And now her heart is 90% occluded, but no. Yeah, they're only getting 10% of the blood flow. So what happens when they start running up the stairs?
Chest pain, angina.
Yeah, and so the heart's a muscle, right?
Yeah.
So what happens when you're doing the 30-pound reps? You develop burn. What's the burn? Is it because you're getting enough oxygen? And yeah, some people will tell you that it's not really lactic acid. I'm not going to argue that point. The point is that muscle's working really hard and it's not getting enough nutrients and oxygen. And so it's gone into an anaerobic mode. Now, your voluntary muscles are actually able to set aside a little bit of extra glycogen, which they can convert back into sugar. Can your heart do that?
No.
Your heart has no reserve. So as soon as it's running low, it starts complaining. And it just happens to be the way our nervous system works. This is, that kind of referred pain kind of thing, which is, internal pain is different than external. So that's why you get the ache or you get the, the back pain or whatever. So yeah, the circumflex goes around the heart, and you don't want any of these occluded, but you particularly don't want the LAD. And so somebody comes in with a 90% occlusion of the LAD is probably on their way to the surgical suite, or at least some really big stents. Depends on what's going on. So what's ejection fraction? It's a percentage, so what do you think it is?
The percent ejected.
I'm sorry? Sounded like I heard. I don't know if it measures contact.
Doesn't it measure the amount of blood flow
Is that what it says up there? Oh, that's what the morning class couldn't figure any of these out. It's like, the answers are right there, guys. No, now they're going to be mad at me.
But it's a percentage compared to what came in as to what went out, correct?
Well, it's not necessarily what came in. Well, yeah, you could state it that way.
that left. It's a percentage that was ejected out into the body.
Okay, well, it's related maybe to stroke volume versus. So what's preload?
When it's filling.
It's actually full and actually stretched. So preload is the number you start with. And the ejection fraction is the percentage that actually goes out based on the stroke volume. So stroke volume is the actual metric, 30 mLs, whatever. And it's 30, if it's 30 out of 40, 75%, that's actually pretty normal. And if you
Preload is stroke volume minus ejection fraction. Is that what you're saying?
No, what I'm saying is preload talks about how stretched and full the heart is.
Ejection fraction.
Ejection fraction is the percentage of blood that leaves with each stroke. the percentage, not the volume. But if you take the volume of blood and divide that by the volume of the preload, you will get the ejection fraction. Does that make sense? Kind of, sort of, okay. And if you have a patient yet with an EF of 20%? 30%? No, not yet, nobody? What would you expect if you had a patient that had a 20% EF? Yeah, they may not be able to do more than 4 or 5 steps. Yeah, they have no cardiac reserve. They are sometimes referred to as cardiac cripples. You know, their heart is so compromised that getting out of bed is a challenge, let alone walking to the bathroom. They're breathing hard, they're working because they have no reserve. Yeah.
So, just to be clear, ejection fraction does not measure contractility, is that what you're saying?
No.
So we should take that one.
You know, it's
Come on, Bob, give it to me straight.
it's related. In essence, you know, if I have an ejection fraction of 80% versus 20%, we're talking about the ability of my heart to pump, which is contractility.
Okay.
But, yeah, I wouldn't relate it directly. Yeah,
Kind of influence.
kind of, yeah.
I mean, it does because if your heart wasn't contracting, there would be no.
Right. So it is generally correct, but I wouldn't say that there's a specific number. Contractility is usually measured other ways because there are drugs that are, you won't know about this yet, but in your pharm class you will eventually learn about drugs that are called inotropes. Inotropes. Do you? Tell me what you know.
I just know that it's the contraction.
Yeah, they affect the contractility of the heart. Yeah, as opposed to chronotropes. What are chronotropes? Yes, so metoprolol slows it down. What is? Yeah, digitalis does too. Yeah. What about epinephrine? It increases what? Well, it's also both it does both. It increases both contractility, strength of the contraction, as well as the rate. But that's not part of this lecture. So let's. So we talked about cardiac output. So actually, I didn't really specifically talking about cardiac output. What is the cardiac output? How do you get that number? Heart rate. So the stroke volume, let's say it's 30 mLs times 60 beats per minute, is going to be 60 times 30, isn't that about 1,800? About 2 liters a minute. And that's actually probably not too far off. I mean, your heart really, it does this for it's been doing it for me for 65 years. It's tired. No. Okay. Preload, what's afterload? The pressure against which it has to push. So if your diastolic blood pressure is 110, what's going on for your heart? What's that going to do to your ejection fraction? Probably decrease it. Yeah. Okay. All kinds of. Look, if you've got a diastolic of 110, you're probably in the ICU, because that probably means you probably have a refractory hypertension, and you're probably sitting at 210 over 110, and they're waiting for something to explode. They're going to stroke any time now. It's a hemorrhagic stroke waiting to happen. No, I'm serious. I've had patients like this, let's give them something, please, because they're going to go. Anyway. Can I modify my age? No. I can on Facebook. Can I modify my weight? Yes, I can. I'm working at it. Yeah, I can. I'm probably still Caucasian. I'll have to ask my Scottish grandfathers. Stress level, what can I do about that? Retire. I can retire. Maybe next year. It used to be that gender wasn't modifiable, but I'm no longer sure about that one. If you live in San Francisco, it can be anything you want it to be. What about your cholesterol level? Within limits. So, now when I was 30, that was about 30-ish, that was when they said, you can't eat eggs, you can't eat steak, get rid of all of the dietary cholesterol. Now, just recently they said, oh, dietary cholesterol doesn't really matter. Why the change? What's different? What did they finally figure out to tell the rest of the population? Which most doctors have actually known, but at least the researchers. Not exercise, no. Nobody's got a really good guess? Yeah. What they actually figured out, though, was that dietary cholesterol has almost no impact on your blood serum levels. What makes cholesterol? What organ? Liver, yes. When does it make it? It's spare. Well, when is it? When do we do a lot of that processing?
Sleeping.
Yeah.
That's why I said that.
That's why I didn't say no. Were you just stretching, or did you have a question back there? No, were you asking? She's tired. Okay. I'm tired too. I didn't want to get up this morning. The alarm went off at 4:45, and I'm like, oh no, it's Wednesday. Yes, it is. So you beat me. So when do you want to have somebody take their statin? You have a question or you have an answer?
At night.
No, I don't think. Unfortunately, I don't think it works that way. So, like, if I only sleep 4 hours a night, my cholesterol level should go down. No, actually, it probably works.
Probably go up.
Actually, more likely to work the other way, just because insufficient sleep is a high stress, and stress increases your cholesterol. But
So
yeah.
we give the statin at night.
Yes, that's why you'll see that the directions for the statins are taken in the evening, probably with or after your meal. Exactly. Well, yeah, because why? You don't want to get up and pee at 3 a.m. Right.
You want to give it before breakfast?
Now, obviously, we can't modify our alcohol intake because we need to maintain that to be good nurses.
We need to be able to relate to our patients.
Exactly. I know about that. Okay, so we can manage our activity, we can manage our alcohol diet, we can manage our diabetes. I mean, and actually with type 2, there's a lot of evidence showing that you can not only manage it, you can prevent it, and yeah, diet and exercise, salt intake. Okay. So what's the problem with the low density lipids versus the high density, the HDL versus LDL?
One of them was
LDL is fat.
Let her finish. She,
I thought the HDL was the one that recycles, like it moves all of the LDLs around.
well, so it's primarily the lipid. Your cholesterol is involved in transport of stuff. What happens with the low density lipid, the low LDL? What's one of its primary issues?
Is it something with the structure?
Well, it's actually associated with in the inflammatory process. And so we're going to get into that in just a moment here, I think. We're going to talk about inflammation and stuff. Well, first we will talk about all these good things, statins. So you have a patient who's going home on Zocor or Simvastatin or Torvastatin. What are you going to tell them to be particularly aware of? Is there anything that they really probably need to know beyond, should they take it with grapefruit juice? No. Is there anything they need to be on the lookout for?
There is something with statins. I can't remember what
It's important, so you probably want to remember it. It'll be on the NCLEX, I promise you. No, well, maybe it will. I don't know.
we learned this in med-surg one.
Well, you should learn it in MedSurg too, then. So what symptoms might you be having them look for to be aware of? react to? Muscle aches ring a bell for anybody?
No, it kills the muscle. Doesn't it kill the muscle or something?
Yeah. So there's a word that goes with that. There's actually a condition.
I'm trying to remember it.
So if I'm involved in a motorcycle accident and I crush a bunch of muscles, rhabdo, there we go. Okay, excellent. She gets the gold star. So with rhabdo, the muscles start breaking down, and of course you're going to get muscle aches. Where else do you think you might get pain?
Your heart.
To a degree, but I'm thinking of a different set of organs. Kidneys, because they're trying to filter all these massive molecules. They don't like it. So you're going to see change. Their urine's going to turn dark. They're going to feel crappy. So they need to contact the doctor right away on that. Did you all read about fibrates? What do fibrates do? I guess not. Okay. So fibrates work by increasing the secretion of cholesterol into the bile. They increase the secretion of cholesterol into the bile. Where does bile go? And where does it go after that? Yeah. Good. It's the main reason your stool is brown. Anyway, or should be, maybe. And then, of course, resins. Resins also work. They sequester the cholesterol. So when we sequester a jury, what do? They lock them away. So what this does is it locks them away, and then it goes into the bile, into the stool, and away it goes. Those are kind of the old guard. The statins have pretty much replaced them. The people that are on the resins and fibrates are those who can't tolerate statins, for the most part. Let's talk angina or chest pain. Well, what's the goal? Stop that! What? And what's causing that pain? Lack of nutrients, oxygen, glucose, all that stuff, caused by. So ischemia. So the blockage. This guy with the 90% occluded LAD. Yeah, he's trying to walk up the stairs, and his heart says, "Give me more blood," and he says, "I can't." It's like the plumbing in a 90-year-old building. It doesn't work real well, but the house is really pretty. My wife likes the old craftsman style homes. It's like, I'm glad we have a newer one. It's okay. I was a building contractor once. I don't want to fix things anymore. Maybe, but then you have to pay for it. They're expensive. So let's talk about things that go on with angina. How do you decrease the demand, and how do you increase oxygen? Okay. Well, the nitroglycerin relieves the pain. How? And that causes what? But what else does it do? No, not so much bradycardia. It actually reduces. It also vasodilates the heart, so it increases blood flow to the heart, as well as decreasing your blood pressure, which decreases the workload and your afterload. So it doesn't have to work as hard, and by increasing the cardiac circulation, each breath you take gets a little more oxygen. That's not generally considered a good choice. You might have a 30/10 blood pressure before you die. It's very hard to treat, actually. It's hard to support. Yeah, that's why it's a big deal. Oh yeah. I've had 50/20. Not me, one of my patients. Yeah, if I was 50/20, you'd be calling 911. But so okay, you're a nurse now. You guys aren't critical care nurses, But you're on the floor, and suddenly you walk into the patient's room, and they are 50/30. What are you going to do? Doesn't that need doctor's orders? What are you going to do? We're back to nursing priorities. What are you going to do in that room?
Actually, the first thing I do is take a manual blood pressure.
At 50/30, you probably won't really need to take the blood pressure because their eyes are probably rolled up into the back of their head. But yeah, no, that's, so yeah, you could certainly, I need help here, shout it out. What else could you do? What can you do in that moment to improve blood flow back to the heart and the brain?
Do you lay them flat?
So you're certainly going to get them down flat. Can you do more than that? What can you do with a hospital bed? So that's called what? Reverse Trendelenburg. You can put them at like 30 degrees, put their head down so it's just everything's running down that direction. That'll help. That is, you don't need an order to do that. John, you're going to get us all in trouble. Well, let's keep it clean. Come on, guys. Yeah, I'll have to bleep that one. I don't know.
Really? And the audio comment.
Okay, so there's things you might press the code button. Do you know where the code button is in your rooms? Yeah, y'all should know where the code button is.
Right in the hallway. Help!
There's that one, but there's also a button in every hospital room that says code blue. Now, in the hospital I'm working in right now with my students at Sutter, they ran into a little problem because they decided to make them accessible for wheelchair-bound people and everything else. So they moved everything down. It used to be the code button was up here above the bed. Guess what? The 3-year-old walks in and goes, pushes the button. So they've had to put a little guard thing over the, you have to lift it up and press the button. There's no right answer to this stuff. But yeah, don't hesitate. Call the code. What's the worst thing that can happen? You can call a code and the patient's actually okay. They'll talk to you about it. And they'll say, well, what was your assessment? Well, I saw this going on. Okay, well, good. You can't go wrong doing that. Can you go wrong by not calling the code?
Yes.
So that makes that an easy answer, doesn't it? Okay. That's 9, and I'm on 9. Let's go for 10. So Mr. Lawn Mower here came to your ER, and he's complaining that he has this radiating chest pain in his jaw, blah, blah, blah. And you give him, what's SL? Sublingual, great. That's not, never mind. And we know what O2 is, okay. And then 5 minutes later, he's fine. So is that stable or unstable angina?
Stable.
What would make it unstable? Not doing anything. He's in a recliner. So what's the difference? What's going on with unstable that's not happening with stable? We know that it's different and it's actually pretty dangerous and unpredictable. What do you think is actually going on anatomically, physiologically, that is why stable or unstable is different from stable?
Either they've got a blockage or they've got
So your heart rate be elevated while you're just at rest?
Worse because when you're stable, you could have provoked it by making something, but unstable.
knee phase versus
What did you like for stable? You prevent from going into the heart?
Well, I'm not talking about prevention. I'm talking about really what's the underlying thing that's going on that is causing it to be considered unstable versus stable. So stable means, this probably just, he's got an occlusion, and he's got limits on what he can do, but if he sits down and rests, he's okay. Unstable usually implies that there's maybe some other kind of inflammation and damage. Maybe the plaques have actually ruptured, and there are clots forming and breaking down, And so it's getting worse and maybe get better and could get worse. And it could get so worse that, he dies. That's what's going on. And that's why it's so dangerous and unpredictable. And somebody comes into the hospital with unstable angina, they're usually scheduled for, maybe, PCI or percutaneous intervention or a cabbage. Cabbages don't grow in the fields. What's a cabbage?
Coronary bypass graft.
What's the A stand for? There you go. Coronary artery bypass graft. Here we go. Cabbage. So you'll be reading about history and say cabbage times 3. What does that mean? No, actually what it'll mean is 3 vessels. They went in, they looked, they had 3 occluded vessels, and it was more than they could handle with stents and stuff like that. So where am I here? 11. Let's talk about this for a second. So somebody that comes in with an unstable angina, they're likely candidates for a graft, a cabbage, or stent placement. They may try and manage them with meds as much as they can and manage the inflammation. I think that's what I wanted to talk about there. I love this slide because it's actually not true. If you're male and 50, it's pretty true. If you're female, it's pretty untrue. Why is that? Why do we know so little about women and heart attacks?
Usually die from heart attack.
No, that's actually not true. Well, who did they do all the studies on? Because women have different symptoms, and so they weren't identified. So men came in with these classic symptoms. Oh, you're having a heart attack. Okay, good. What women can often have very diffuse symptoms. Low back pain, fatigue, malaise, heartburn, yeah. So they were identified as, other things, except they died. Or maybe, or they had, a sublethal heart attack and they continued on. And particularly, we'll save that for the slide that's coming up. So what is your priority with a patient that's having chest pain? What is your priority? Have them lie down. Tell them to stay calm. You'll be okay. Don't ever say patient. Don't ever tell a patient they'll be okay, because you have no way of knowing if they will. Yeah, have them lie down. Give them oxygen, nitrates. What's the standard dosing for nitroglycerin? 5 months? And it's okay. Once every 5 months, we'll give you a pill. No, I'm sorry, I'm giving you a bad time. So yeah, how many doses?
3. Isn't it 1 every 5 minutes?
Mm-hmm. And if the pain is not resolved after 5 minutes, or 15 minutes, 3 doses? Well, you probably already called the doctor, but we're in the hospital right now. We're in the ED, so you go to them, there are 3 SL doses. So what do you start thinking about this patient now?
We're going downhill.
Well, is it angina? No. Probably not. Well, oh, absolutely. You ask that before you give them. What's in addition to the sublingual? How else at home? How else do people sometimes have? Yeah, they can do a spray. So why do you give it sublingual? What's the rationale for that? Yeah, you got all kinds of blood vessels down there, so it's quick. What's the advantage of the spray? Do your lungs do they have more vasculature than under your tongue? Yeah, it's like instantaneous. Although I vaguely remember, this is just popping into my head, and it could be, I'm making it up. I don't think so. that the incidence of like a migraine type headache is higher with the spray than it is with the sublingual, but I'm not sure of that. I think it's because of the rapid onset, but it's like, yeah, the spray, it's like boom, it's right there. That's why they give things inhalers for certain conditions, because it's like right now. You can, even during a code, you can have them inhale like the epinephrine and stuff if you have no IV access. Or they can give it through the bone, but that's more exciting. Now this is about where I stopped yesterday morning. Shall we take, let's see, when does this class end? Like an hour from now?
Yeah.
So let's take, what do you need, 5, 10? Tell me. 7. Okay, at 5 after, we will resume, and then somebody will tell me at about 20, 35, 40 after that it's time to shut up. Oh, you have extra cast. You have 5 people. You can really span the whole thing. Okay, well, let's start again. It's been a certain amount of time. He'll return.
Because, I mean, I'm happy for him. I should text him and be like, I hope all is well.
What do you, I think we take a picture?
Actually, you know what? I should
I-
send him a thumbs up.
I think it's time for us to start class. This is deteriorating rapidly, and I'm going to get in trouble. So,
This is actually great.
Give him a link to what?
so after you have your Altoid, can I start?
Sorry.
Okay.
I just thumbs up to him.
All right. Bob is starting now. I've been a little too lax. I'm going to have to really, clamp down. So how does a heart attack actually happen? It's all up there. Yes. So I've covered that slide. You're good to go. I can ask you any question on the test about how heart attacks happen, right? So it actually starts out with these clumps, these atheromas, which are basically little clumps of fat. And LDL cholesterol plays a real role in that. So as long as those clumps kind of remain smooth and everything, it's probably, almost all of us have some level of plaque. But if they become inflamed, roughened, you realize that we actually are forming microclots and breaking them down all the time, all of us. So if you have this surface that now is inflamed and rough and scraggly, and a little microclot comes by and hangs on the edge, maybe the next microclot comes on and hangs onto it too, and you start developing, a clot. And that's the concern. And this is kind of how really, like even unstable angina begins. You've got this breakdown and stuff starting to accumulate, and maybe the clot suddenly gets a lot larger, occludes, and then it breaks down, and the pain goes away. But that's really what you're getting into when you get into a coronary syndrome. And inflammation is underlying all of this. In fact, there's a fair amount of research now that sort of indicates that the inflammatory process may be the basis of almost all of our disease processes, that it plays a role in everything. So with stable angina, you get this plaque, and it basically just partially occludes. And that's why with exercise, it's going to impair the flow, and you get pain, and when you stop, it's able to deliver sufficient, and everything's happy. With unstable, now maybe that atheroma has ruptured, and now it's starting to capture stuff and build a larger clot. And if the tissue starts to die, what do we call that? Infarct, right? You got it. So how is a patient who's having an MI going to present differently to you in your ED than a person who's got angina? What's going to be different as you treat them and follow your protocols? How are they going to respond differently than the angina patient? What's going to be different with the MI patient?
As opposed to the nitro area talked about?
So they don't respond to the nitro. If you give them If you give them morphine, does it make the pain go away?
For the angina or the MI?
Well, you don't normally give morphine for angina, actually, because then they can't drive home. No. So morphine, we're going to talk about morphine in a minute here. We'll get to Mona. Does improve cardiac circulation. It improves cardiac oxygenation. It also, again, reduces afterload, and it relieves anxiety because it relieves pain. But if they're having an MI, they're still going to have pain because it doesn't fix the problem. If they're having angina, typically the nitrates will hopefully resolve the problem. So let's talk about the EKG. And now you took that test, you know about the PR interval and the ST interval and the QRS and the T waves and all that good stuff, right? So when somebody is having angina changes, their EKG looks different than somebody that has an MI. Have any of you taken care of a patient that had a STEMI? No, you haven't seen that in their chart yet. You've seen STEMI. Have you seen NSTEMI? Not yet? Oh, you should see that almost equally. So what does STEMI stand for? It's an ST, elevation,
Elevation myocardial infarction.
MI. So what do you think an NSTEMI stands for? Non-STEMI elevation MI. I know, this is really hard. Okay. So the thing about the ST, so this ST segment, which should be, well, we don't have a normal one here. If you had a normal, you would have another segment here before the, that T wave. So the ST segment should be at the same level as, it should be, isoelectric, which means the same electrical level as the baseline. So when they talk about elevation, they're talking about this segment here being higher than normal. And that indicates damage. Ischemia, let's see if I remember this correctly, because I have been known to, yes. With injury, you get ST elevation. You can get ST depression, which is an NSTEMI, and it may or may not have injury. It definitely has ischemia. So somebody that has ST depression is perhaps on track to have ST elevation with permanent damage. ST elevation indicates that there's damage going on. And with an infarction, actually Q waves, you kind of see them, you kind of don't. They come and go. Q waves are often hidden in the T wave. So you may or may not see a Q wave inversion. But maybe. Depends. So the Q wave is this thing by here, not this. It's this. So you have the P, QRST. Normally Q is actually here. It shouldn't be down there. Don't you love how they use the alphabet to describe this? It makes it easy. And then you'll find you get into Q prime and R prime and S prime, but you won't be doing that in here. But you will frequently see in your history and physicals about them having a STEMI or an NSTEMI, and this is going to relate to what the quality of their heart is afterwards. How much damage was there to the tissue? What happened to the heart muscle in that process? So what's troponin? Yeah, when's it released? Yeah, on cell death. And that's actually a pretty accurate indicator. So when you have that patient that comes in who is not, the nitro doesn't resolve, and they do an EKG and they see ST elevation, they draw labs, right? They'll often just say, draw cardiac enzymes. What are they looking for?
Any indication?
Cell death, not heart cell death.
Yeah. How quickly does that happen with the troponins?
I'm gonna guess 3 hours or 3 weeks.
Let me guess, yeah. How often do you draw cardiac enzymes? What's the standard? No, actually not every 3. Every 6. And usually just for 3 draws. Because they want to see if there's an elevation in the troponins and if is it continuing or dropping. Yeah. 6 hours. Yeah, they don't keep them in the ED that long. But they may keep them in the ED long enough to draw the first lab and 6 hours later draw the second lab to see if there's troponins or troponin leak and if it's going up or down.
Does 3 draws max or 2 draws?
Well, it depends. The standard order is for 3, but often the third one doesn't get drawn if they're starting to decline. So if it's continuing to rise, you'll draw the third one. And if it peaked and they caught it later, in the process as it's going back down, then they may or may not. So these others show up, but what's the problem with myoglobin? Why is it less useful? Where else do you have myoglobin? All your muscles. So any kind of muscle damage will lead to myoglobin. CKs are pretty useful. So which of these patients is the most likely to be difficult to diagnose? Who's the hardest one to figure out that is having a heart attack? I'll go, there's 2 women up there. Which one? Oh, the one with diabetes. Yeah. This gets back to that discussion earlier about that one slide that's really not very accurate. Diabetic patients in particular, because of their neuropathies, have weird symptoms or not abnormal symptoms, if you want, or lack of symptoms, exactly. So Mona is not a girl that I used to know. No, that never mind. This is a great acronym. It's easy to remember. Is it the order that you give the drugs? No. What do you give first? Well, actually, oxygen is no longer the first thing you give. Nitroglycerin. Yeah. Yeah.
Really?
Skepticism back there.
Well, what if their sats are 98%? Say, I hate to admit this, but I'm probably in league with you. I would probably put oxygen on them anyway. But the current standard says 95% or above, they don't really need oxygen because they're getting enough oxygen.
What if they're anemic? That won't give you an accurate reading.
You're probably not going to get in trouble for putting oxygen on a patient. You might get in trouble for not putting oxygen on a patient. Oh, in my judgment, I thought they didn't need it. Are you a doctor? Well, no, not really, but my instructor said, yeah. So oxygen is still in there, but typically the order of administration is nitroglycerin followed by aspirin, followed by morphine and oxygen. And the oxygen is, PRN based on their O2 sats. Why? How is that aspirin given? And what's the dose? Do you give them a full tablet? 385 grams? That's actually the standard dose for, also the standard dose for this is 81. They may say grains 325. I don't know, but really, and do they swallow it? Do they chew it? They swallow it. Yeah, sublingual is going to be uncomfortable, and it's. I like the orange. Yes, the children's. So you know way too much about me already. Okay, give him the orange. Bob likes that. So you're going to give nitroglycerin, you're going to give aspirin, oxygen, and if those aren't working, you're going to give the morphine. And the morphine, you'll need orders for the morphine. You need orders for pretty much everything except the oxygen, maybe. Oxygen's a medication, but it's within our protocol. If we think a patient needs oxygen, we can put that nasal cannula on. Yeah.
Now, if the oxygen level is below 95,
Oh, I definitely put oxygen on them.
what would you still?
Well, what I do, if it was my patient, since that nasal cannula is probably right there, I would probably put the oxygen on and then go get the nitro. Because the nitro's in the Pyxis, and I got to go get it. I can put oxygen on them right now. So, in truth, yes, I'm going to hang oxygen on them, go get the nitro, or go ask somebody to get me nitro or whatever, and I'll be taking their blood pressure, and but maybe you can get some aspirin too, or whatever. It's all going to happen pretty much at the same time.
You use the cannula instead of a non-rebreather at that point?
Depends on whether they got respiratory issues or not. Yeah.
I have a question about the MI. So when you use the nitro, would you get like 3 doses? Because you got to do 15-minute, or would you only get 1? In your opinion?
Well, what's the protocol? It's one every 5 minutes or until the pain. If the pain's relieved after 2, you stop. If the pain's not relieved, you go to the third. And if the pain's not relieved after the third, it's probably not an angina.
I'm sure in the ER we're going to get people.
You throw them in. They put that oxygen on right away, don't they?
Like someone was out in the field and if we brought him via ambulance,
They're going to come in with oxygen on already, and you're going to get that.
we have a dosage with nitro.
Maybe. They'll give you that in a report.
Depends on if it's a BLS or ALS.
Or whether or not they walked in. I'm having chest pain. People come in all the time and say, I've had chest pain for the last 2 days.
Well, I guess the question is if they do come in via ambulance, if they feel
Then you're going to get a whole report based on whatever they've already done over the phone. Yeah. So they may have already done that, and they've already gotten an EKG, and they already know whether or not they're having an MI. Yeah. But good question. So what's the deal with morphine? What's it accomplish?
Decreases the demand.
What else does it do?
Well, pain.
And what does that do? Am I anxious if I'm hurting? Yeah. Yep. Probably. What are you going to watch out for when you give this? Yeah. Don't put your fingers in the patient's mouth. Chomp. It happens. Yeah. Watch their blood pressure. You're going to need to monitor that, especially if they forgot to tell you they took Viagra. Women take Viagra sometimes. It's been known to happen.
For the same-ish
I honestly don't really know the reason. But when you have anything that supposedly relates to sex, almost everybody wants to try it at least once. Okay, well, we'll let that one go right on by. So what do these all have in common?
anticoagulation.
Do any of them break down clots?
No.
No. So they only help prevent clots, right? What's the difference between Plavix, heparin? Yeah, between just Plavix and heparin. What is the main difference between the two of those?
They're different medications.
Well, there is that. They are different medications. Can you reverse both of them?
No.
What's the antidote for heparin?
Protamine sulfate.
Protamine sulfate. Is there an antidote for Plavix?
No.
No. Exactly. What was that? That's why Bob takes Coumadin. You guys know way too much about me. So when would you be cautious about giving a beta blocker?
They have asthma.
Very good. Right off the top of your head. Excellent. How many beta, what kind of beta receptors do we have?
On the heart, beta 1 and beta
Beta 2s are where?
in the lungs.
Right. Yeah, 2 and 1. Or 1 and 2. I said that this morning and then it was like, oh my God, what a great mnemonic. It's like, haven't I said that before? Anyway. I think they need more caffeine in the morning. So how can this, oh, you have a question? For which one? Oh, the beta 1 and 2? So you have 2 lungs, which have beta 2 receptors, and you have 1 heart. That's a good one to remember for the NCLEX, actually. It will come up. Because the risk with beta blockers is, what can happen? Asthma. What if they're a COPD? Same problem.
They need a calcium channel blocker.
That's why you need to select it.
So there was a question on the farm test I gave 2 weeks ago that said, and it listed those same 3 drugs, and it said, which of these is 100% cardioselective? None of them, exactly. You guys could pass that test. Some of the students in that class were struggling more. So what are 2 functions of ACE inhibitors? What are they? How are they different? What does ACE stand for?
Angiotensin converting enzyme inhibitor.
Inhibitor. So what does angiotensin make?
Angiotensin 2.
And what does that make?
Renin.
Renin. And what does that do?
It
It's a very potent, so what we're going to do is prevent the vasoconstriction, which is going to lower blood pressure. What is one of the beneficial side effects of ACE inhibitors? Of course, it lowers blood pressure, and they have a diuretic effect as well, which also lowers afterload. You were just stretching. Okay. But there's a real benefit to ACE inhibitors. Having somebody on an ACE inhibitor that is hypertensive, particularly if they're diabetic, they can derive a great benefit from that drug.
spare the kidneys.
How does it spare their kidneys? You're at least you have two of the right 3 organs.
I'm going to say something to do with their sodium.
Actually, it's not about the sodium level. I'm sorry. Okay, what happens to organs when they're under high blood pressure all the time?
Well, they get damaged.
So,
Glomeruli.
yeah, there's a name for that. Have you ever heard the term remodeling?
Yes.
So cardiac remodeling, renal remodeling. So ACE inhibitors are very effective at preventing renal remodeling and cardiac remodeling. So for your diabetic patient who is very susceptible to that, who's likely to end up on dialysis because of their renal failure, ACE inhibitors are very useful for them in preventing that outcome, hopefully. Of course, you have to start them on it soon enough. So the 2 functions actually are lower the blood pressure and reduce, they're a diuretic. So they reduce the cardiac, the afterload. What are the primary complications of an MI? Post-MI. It's on the board. You don't have to guess. So dysrhythmias are the very first thing that they have. After they've had an MI, they have all kinds of, the heart is like, it's like a car that's running on 6 cylinders out of the 8, and sometimes the other 2 are kicking in. Maybe. So
I've just had that problem with my
which 2 was it that were bad? Never mind. And actually, when you have a patient that they've placed stents, they came in, they were having an MI, they went into the cath lab, they placed stents, they will have reperfusion dysrhythmias. because the heart is like, it's, your leg goes to sleep, and then, you move and it starts, and suddenly it's hypersensitive, at least for a little bit. You touch it and it's, yeah.
So obviously dead is dead. We're talking about the tissue. So we're talking about the marginally perfused cells coming back.
Yeah,
Okay.
they're recovering. And in that process, they become, you got to remember, cardiac cells normally talk to each other, and, you've got the Purkinje fibers and the whole conduction system. But after an MI, there's disruption to that. And you've got these cells that are damaged, but not necessarily dead. But now they're responding in their own way, and you suddenly have a place that's firing on its own. And so what do you get? You get PVCs, you get PACs, you get all these. And as if you're in the cardiac unit, what you'll be looking for is runs of PVCs. You'll report, he had a run of 3, run of 10. He's been having runs of 4 to 5 every 10 minutes. Those kinds of things you're going to be calling doctor about, because that indicates that things are not stable.
Do they tend to stabilize after a while?
Hopefully. It depends on how much damage. I mean, everybody's an individual at that level. So heart failure. What does heart failure mean? We were talking about cardiac output, ejection fraction. Yeah, so their heart's really, it's not able to work as well. You've damaged, you're developing, over time you'll develop scar tissue, and that part of the heart really won't function. And you'll see in their echocardiograms, they'll talk about lack of motility in the walls and stuff that tells you how extensive the damage was. They look at how much of the muscle is actually able to contract. Cardiogenic shock is, this heart is really damaged, and it's having real trouble recovering. It really can't pump effectively. Somebody in cardiogenic shock is going to be susceptible particularly to things like pulseless electrical activity, PEA, which means on the EKG they look fine, but their eyes are rolled up and they're out, because their heart's actually not working. The impulses are there, but the muscle's not moving. So these patients may need quite a bit of assist. You may put them on a VAD, a ventricular assist device. I used to take care of a lot of patients with an IABP, an intra-aortic balloon pump. And so what that is, it's actually a really pretty slick technology. They run a catheter up into the aorta, and it's about that long, and it's a balloon. It's about the size of, about that big, a couple centimeters around. And it inflates in milliseconds with helium and then deflates. Now it's hooked up to their EKG, so what it's doing is the heart contracts and kicks blood into the aorta, and that thing inflates. So you've got a valve there that prevents backflow, right? So that, in essence, pushes the blood out of the way, pushes the blood to the rest of the body, reduces the cardiac workload, because it no longer really having to push against it. It deflates, and so the next time the heart pumps, there's nothing in the way. So there's really very, it's like it really reduces the cardiac workload. Now the downside of these pumps is they actually use helium because it's such a light gas and it moves really effectively in these pumps. Helium will cause instant clotting. So if you have a leak in your balloon, it's a big deal. Yeah.
So would you also want to have a patient on a pacemaker for good efficiency, or?
They may or may not be on a pacemaker. A lot of times this is like post-surgery and stuff, or the post-MI, and they haven't had time to put anything in yet. It's a supportive measure to keep them going long enough to figure out what to do next, and to see if their heart's really going to make it on their own. I mean, they may be, if the damage is to the conduction system in such a way that there's dysynchrony, then yeah, they may need a pacemaker, and they may do a percutaneous pacemaker. They may actually run an external pacemaker into again through the femoral and into the heart, and until they can put a permanent pacemaker in. And if you have a patient that has an external pacemaker, you always wear gloves to handle that, because a static discharge could be very bad for your patient. Anybody want to guess? What was the number one dysrhythmia a couple of pages back? Or dysrhythmia? Oh, that gave it away. There's Bob's mnemonic. Okay. Dysrhythmias. People who have had heart attacks are dysrhythmic, easily dysrhythmic. And they go into things like VFib, torsades, which we'll talk about another day. Probably not even in this class, but there's all kinds of fatal dysrhythmias that you'll learn about in your ACLS classes. What are thrombolytics? Who gets them? People who haven't had surgery, all kinds of stuff. This is like, okay, we're going to try and bust the clot, and then if that's not going to work, we're going to go to a PCI, which is like stent placement, or a CABG. What's CABG stand for? You guys are good. So does this guy get TPA or streptokinase? Or maybe... Right. So this is a stent. Really exciting. It kind of looks like the old, the Chinese finger jails or whatever. That's really kind of what it looks like. They shove that in, and it's got a little balloon inside, and they increase that to like 30 atmospheres of pressure, and it's expanded out because it's made out of like steel, surgical steel. Sometimes they're coated with drugs. You can have drug-eluting stents, and they'll have things like, they'll have Plavix or whatever on them. Or sometimes they just do a balloon angioplasty. What's a balloon angioplasty? That's the one on top. They just go in and try and crush the plaque, and hopefully it stays crushed, rather than placing a stent.
Would it run the risk of breaking off if you crush it?
I guess. I'm going to have to trust that the cardiologists have a clue about what they're doing. There have been times I've wondered. So when they do a bypass graft, and we're down to like the last 5 minutes, right? Because we need to do a presentation. You need to supply a new vessel to, they'll do a 3-vessel or 4-vessel graft. What vessels do they use for the bypass? Yeah, what's the name of that? It has a name. No, it's not his name. It's neither of those, unfortunately. Saphenous? Yeah, it's a great name. Saphenous vein. SAPHAPHENIOUS, if I remember correctly. Or they'll use like the internal mammary. Where does that go?
Where does it go?
Yeah, where does the internal mammary normally go? Chest wall. Goes actually it doesn't go to the mammary, it just goes to the chest wall. It just happens to be near the mammary gland. You guys.
I like the way you think.
Okay, well, anyway. What do you think they have to be concerned about with using a vein versus an artery? If they use the vein,
The muscle and the if you use the vein, there's not enough.
You want to explain that? He's on the right track here. Why does this side go up?
Because there are valves in there.
There's valves in the veins, and there's no valves in arteries. So if you put the vein in backwards, it doesn't work. So we have various kinds of stress tests. We can put electrodes, and they do this treadmill, and you tell them not to eat breakfast before they do the treadmill because they'll puke all over everything. They take them up to their max, and they look for changes in their EKG. They look for ST elevation or depression. If they are too ill to tolerate a physical stress test, we can give them a thallium scan. Thallium scan actually works a little bit differently. It's a radioactive isotope, and they basically take a picture to see where the hot and cold spots are in the heart, and as they increase, and they may actually increase their heart rate chemically, and they look to see if there's cold spots, if there's areas that aren't getting perfusion. So cardiac rehab and recovery. What do we need to know about this? What page am I on anyway? 34. So immediately after the event, the patient is going to be recovering from a heart attack, and they might have had a CABG or a PCA, and they just gradually begin to increase their, their activity levels. Walking down the hall is, that's a big step. During the 6 weeks, they're going to be slowly increasing their activity. They're going to be visited by a visiting nurse. They're going to be, starting a rehab program. And then they begin that exercise program that goes for about 4 months. And then after that, forever, they are exercising and going in occasionally for tests to see how they're doing and how they're maintaining. And then there's the big question. What about sex? Because you will get asked this question by your cardiac patients. When can we start again?
When your heart is
So,
stable.
but how do they know when their heart is stable? If they can walk up 2 flights of stairs without any discomfort, without having to stop, no angina, that'll be okay. And they probably can't mess around with, like, they can't have a mistress and stuff like that. They can't have anybody too exciting. They have to stick with their old partner. Okay.